they need to do extraction of this remaining root, the residual root. But you can see that if I do an extraction, what about the prognosis of this canine? So ideally, this patient need to be referred first for redoing root canal, temporizing, or doing a good filling, and then we will discuss the extraction. And if it is possible to do an implant. But unfortunately, most of the time, the patient referred, tell him, you go to the specialist, he will do the job, and then. So can it be done without taking care of this canine? Other case, same, no logical sequencing. They do the general dental examination, they take a panoramic X-ray, and they told the patient, you need to go to a periodontist or to an oral surgeon, you need extraction and implant therapy. But general dentist can do basic work like simple extractions and caries therapy and scaling at least, and then refer the patient for a proper treatment plan. You can see this is the same patient. You can see that he has a deep bite, proximal caries, calculus, stains, remaining root. So there is no plan suggested to this patient. So how the specialist will directly go to extraction and implant if we don't do the basic dental treatment as we discussed before? So if we want a predictable outcome. Different type of wrong sequencing and misplant case. You can see implant has been done, teeth had been extracted in the different intervals of time. We have the lower premolar, lower first molar. Their prognosis is poor because it cannot be restored. So it's also, we can see the wrong implant positioning sequence because these teeth has been treated on a different episode of time. You can see that the placing of an implant and the implant supported crown with cantilever. So this is also an idea about the wrong sequence and mismanagement of these cases. The result of the same patient, you can see now, extraction of the unrestorable teeth has been done. 2 implant supported crown with cantilever, and we have a big embrasures, food impaction, and the patient is not satisfied because he says, I have a big gap between my implant supported crowns. And if we consider also the prognosis of the tooth number 3-5, that means on the American, it's the number 20. So within time, this tooth, maybe it can have a recurrent caries or a leakage in the root canal. So we will be obliged also to the extraction, and the same story will be again wrong sequence and compromise. The same, this is a case of endoperio complications. You can see on the panoramic, we have endoperio lesions on the tooth 3-5, that tooth number 20. It's indicated for extraction. Extraction has been done. An implant has been placed immediately. A previous implant has been done by other colleague, the last one on the tooth number 3-7. And you can see now these 3 implants. Do we connect them? Do we don't do connection? We have a cantilever. So this also we can consider it's misplanning due to the sequence within the time and the cantilever in the implant supported crown that which will give a big embrasures. Now, different story of misdiagnosis, so misjudgment of the tooth. As we said in the beginning, the treatment plan should have a good planning of the prognosis also. This tooth, the number 13, the American number 6, has, you can see, what is the option? It is a tooth that between 2 implants supported. This is another case of misjudgment of a tooth prognosis. This canine, upper left 3, that means in the American it's 6. So what is the option of this tooth? We need to save it because the tooth will keep the proximal bone between the two implants supported. Or we do extraction and we lose the papilla, or we do a root canal and submerge it to preserve the bone and the crested bone. So this is a discussion that it should be done with the patient, with the specialist, but unfortunately colleagues are referring this patient to do extraction and also an immediate implant. Same, misplant treatment. So this tooth that we just discussed also, it's another case of tooth number 13, upright canine. You can follow the prognosis of this tooth within 4 years. You can see in 2007, this canine has distal caries. Root canal was not performed in 2008, in 2009, how this has been restored, not taking care, leakage of the composite. Other teeth have been restored, sans lift has been done in the upper right. You can see now, unfortunately, when there is no communication or right treatment planning between specialist and colleague, you can see how this prognosis of this canine has been going breakdown through. Again, now, can we consider using multi-system implant in a patient as misplanned or as not going in the good sequence? Or sometimes many operators, patient will be seen by X, he will go to another clinic, other hospital, in the private, in the government. So it is a problem to the logical sequence. I don't think the moment that it's well planned and with a good result, so it can be, why not? Many patient has many implant systems. Sometimes the surgeon will start with a system and then he improve or take a better. So it's not considered as misplanning. Now, we'll go for more clinical cases. Again, for no logical sequence. Case was referred for implant therapy. It has been planned to do extraction for this unrestorable tooth, 1-4, that means number 5 in the American, because they say we cannot restore it. The moment that we remove the composite, no more left over of dental structure. And the tooth number 1-5, it needs a crown. So when I saw this case, I said, okay, I agree, we do extraction, but after tooth preparation and removing the temporary on the 5, I decided that the cervical margin of the tooth need to be supragingival to avoid any periodontal problem later. So logically, we need to start by crown lengthening first and then doing the extraction and implant. And this is what you can see now, the crown lengthening by using internal bevel gingivectomy on the palatal side, internal incision on the buccal side, reflecting the flap, doing apical positioning, and then extraction and immediate implant. When we do the implant in a socket with 2 roots, especially in the upper first premolar, always we need to go toward the palatal roots to be away from the buccal bone to prevent any failure, and this jumping space need to be grafted. Same now. Crown lengthening has been performed, extraction has been done, but you can see, unfortunately, even if the surgical procedure has been well done, you can see the adjacent teeth. So that's the problem with our general dentist or the referral. We have recurrent caries under the composite, and this is need to be treated. The problem that the moment that the implant has been placed and later the crown will be fixed, can we do crown lengthening or apical positioning on these adjacent teeth if they need later crown lengthening? So this is the problem of the sequence when we don't do a full comprehensive treatment plan, at least for a quadrant. That's the healing. The long-term prognosis, you can see a nice peri-implant mucosal seal on the implant, nice healing around the temporary crown. And now, again, the same question, the prognosis of the tooth number 1-3 and 1-6, that means number 3 and number 6. It needs to be restored, it needs to be finalized before the final treatment. Now, I just mentioned that sometimes we are not supposed to do crown lengthening to a tooth to be saved next to an implant, but when there is enough distance, this can be performed. And this is a case where these 2 premolars can be saved, apical positioning flap for in the purpose of crown lengthening, and the implant is a little bit far, so we consider here that we have a proper request by the restorative dentist. Now, we will go for a logical sequence. We discussed many unlogical and misdiagnoses. Now, we have this patient has been referred to be to replace his missing lower first molar on the right side, tooth number 30 on the American, or 4-6. And on my clinical examination, I checked that also the tooth number 4-7 had subgingival restoration, and there were bifurcation class 1 need to be exposed. So periodontal surgery will be performed first, and then an implant will be placed in the missing area. So there's the tooth. You can see the composite, the defected composite, the class 1 bifurcation. So apical position flap has been done in the aim of crown elongation, furcoplasty to solve the class 1 bifurcation. You can see the anatomy of the bifurcation and the buccal side. This is to be done first. So this is the logical sequence of the surgical planning. Then we open our crystal flap on the ridge and subcrystal implant system, diameter 3.5 is replacing, and for this buccal small concavity defect, it was filled by particulated xenograft to do in buccal augmentation. You can see the result. Temporary crown on the last molar, screw retained implant supported crown. But again, we will be facing with non-logical sequence because we have an over contour on the implant crown. There is no proper contact, unfortunately, because our restorative specialist, he decided that he will finalize the implant crown, and he will send the normal crown on the tooth to the general dentist. So no proper contact was being done. But from my side, the surgical specialist, we have a very good peri-implant mucosal integration and contour. You can see the probing on this implant crown is within normal sulcus depth. So that's the X-ray. The day of the placement with the healing collar or gingival former, and the day of the connection of the implant. So 9 months post first stage, you can see that there is now remodeling on the platform of the implant after loading. Now, a logical sequence, when it is planned and well done, we can have a satisfactory peri-implant result. So on this upper left quadrant, the restorative dentist decided that these 2 teeth, the number 13 and 14, cannot be restored, poor prognosis. So we did extraction, we waited, and then healing, implant, and we have a very good implant supported crown with very good peri-implant. Now, it's a good logical sequence because started by extraction, waiting, and implant. But now, if you ask our prosthodontist why he connected these 3 implants, they are parallel, they are in good direction. Always they say it's easier for them, but it's more difficult for the patient for the proximal hygiene. We finished a part of this misplanning and the logical sequence. Now we will go for the proper assessment when we want to do implant surgical placement. So as any procedure, any patient attending our clinic, this is sure we need to go to the medical dental history, if we can have his dental background, if we feel that it's necessary to do a full periodontal chart, and to have the diagnostic tool, X-ray, vitality test, and lab test if there is medically compromised. And in that, all with this information, we can put a diagnosis. In the medical dental histories, especially any medical condition that can interfere with our surgical procedure, medication, the smoking is very important to know. And the most important when we want to do an implant, to ask why did you lost your tooth? If it was for restorative failure, that means cannot be restored after root canal or fracture, or for periodontal disease. Because if it is for periodontal disease, we need to know to predict that future peri-implant complication can happen, or peri-implantitis. Then if any general in the extraoral, the most important, it's the mouth opening. We want to know if the patient can open widely, if there's any plan for implant in the posterior, because we have tools, we have burrs, we have wrenches, and we have hand pieces to be used in this area. Intraoral examination, it's very important. For example, if the patient has stomatitis or a history of desquamative gingivitis, because in this case, we cannot offer him an overdenture or a soft tissue supported implant. We need to check on the 2D X-rays, if there is any remaining root, any impactions. The radiological examination, we know it's a must as a standard in panoramic X-ray 2D to have an idea about the jaw, the dentition, impaction, any cyst, any discovery of any radiological findings, to look for the mental foramen, the lower dental canal, nasal fossa, and we need to plan for the specific site for the implant. And then in some countries, in some cases, some countries, it's a must, like in France, where I have been trained, it's a must to have a cone beam CT for each case. In Dubai, it depends on the difficulty, especially if it is a planning in the maxilla, because we cannot, on panoramic, we cannot judge the buccolingual thickness. These days, as I told you, most of the colleagues, they have a cone beam CT, especially if they will plan for a navigated surgical planning. Now, when we go for implant specific site, we have a site, one or multiple teeth to be planned. What will be the diagnosis and clinical evaluation? So the smile line, very important. If it is a tooth in the upper front teeth, we need to check the periodontal adjacent teeth, if they have a pocket depth, if there is a recession, if there is a bony defect, the papilla, the embrasures, and the thickness of the edentulous crest or ridge, if there is a buccal concavity or a lingual concavity or a defect. We need to check how much we have mesodistal space to decide what will be the implant platform and the crown size. We don't want to have black triangles or big embrasures. The occlusal height, when the restorative dentist will do the anatomy of the crown, it depends on the implant support the crown. It will be triangle or square. Also, this decision should be done with the restorative dentist. It should be a cemented or screw retained. Always screw retained is better because it is retrievable. And especially when we have already bone defect or ridge resorption, also we need to predict by when we check the occlusal height if we are going to have a long implant supported crown. All this need to be evaluated before the surgical step. From periodontal point of view, we need to check our gingival biotype, if it is flat or scalloped, the quality of attached gingiva, because most of the studies, they say it's a must to have at least 2 millimeters of attached gingiva around the implant supported, at least 1 millimeter keratinized, 1 millimeter attached. And if there is a bruxism, a deep bite, to plan when we finish to give the patient a night guard, and the prognosis of the adjacent teeth. Diagnostic study cast. This is maybe as a study model to plan for a mock-up, or if we need a surgical stent, how many implants we need to place, and the diameter, and especially if it will be needed with a 3D CBCT for navigation surgery. Now, an example of partially edentulous maxillary place, we need to put implant in this maxillary area. We are going to use a bone level system. It is, you can see the ridge, it's reasonable. We have good attached gingiva, a crestal, always crestal or envelope flap or book flap, full thickness reflection from buccal, from lingual. We, with the periodontal probe, we check the mesodistal space. We know that the center of the implant, it depends on the diameter of the implant. We need to be at least 3 millimeter away from, 1.5 millimeter away from a tooth. And if we take a regular platform implant, that means between 3.5 to 5. So if we do the calculation, it should be minimum 5 millimeter. We should be away of a tooth. It will give us the center of the implant. So this is the pin guide after doing our first pilot drill. 3 implants were placed. You can see the osteotomy. This is the XIF system. The yellow 10 base, it will tell us this is, I'm having the diameter 3.8. And when we have very good primary stability, and when we follow the manufacturer drilling sequence, we have very good primary stability, so we can do stage 1 and stage 2 on the same time, and we reposition the peri-implant mucosa around the gingiva former. So that's the pre-op X-ray. The post-op X-ray, you can see how this implant are well placed and almost parallel direction, and with good distance, 1.5 millimeter between the implant and the tooth, and at least 3 millimeter between each enter implants. Case 2. In the posterior mandible, the same, using bone level implant. You can see here that from the occlusal view, we can do, when we do our palpation, and on you can check that we have a thin ridge. So this ridge has a previous guided bone regeneration with the xenograft particulate in the stage of the extraction. We can see even almost 6 to 8 months after that, there is still some xenograft particulate integrated in the ridge. And you can notice that this patient has severe generalized periodontal disease due to that it's maintained. We have attachment loss. It can be seen by the recession around the teeth. So full thickness mid-crestal flap has been done. Osteotomy has been performed to place 3 implants. You can see the direction of the pin guides. And the first implant, you can see that already we have buccal fenestrations. And this is where the previous socket graft has been done. When placing the implant, because you know always it needs to be under prepared, especially in a socket grafted area. You can see that I have a complete buccal dehiscence. Decortication has been performed to re-graft this area by using xenograft particulate with the barrier membrane and closure. But unfortunately, I can tell you that this first implant has failed, and we have only left this 2 molar implants. Now, the OPG shows proximity to the lower dental canal, and you can tell me why I didn't take cone beam CT. At that time, years ago, we didn't have yet the cone beam CT in our practice, but our radiographic technician was able to do a tomogram, and it shows that we have, sorry, in accurate locations, we don't have a damage to the inferior alveolar nerve, so it was only a superposition on the 2D dimension X-ray. But these days, sure, we need to plan for it as a pre-op cone beam CT. We will know how much will be the length of our implant and how far we can go. Always, we need to have 2 millimeter as a safety margin with the inferior alveolar nerve. Now, this case, like a study case, I presented this in one of the conference in Hamburg in Germany. So we will put the diagnosis and we will discuss the treatment plan. 36 years old male, he had missing this tooth number 14, upper right, first premolar. Number 4, healthy, fair oral hygiene, not smoker. We have a narrow mesodistal space. This is in the logical diagnosis treatment. We can see that we have a buccal bony ridge defect and a thin ridge, but good attached gingiva. So what will be the option to give to the patient? So we suggest we go always from the easier to the most predictable or the most complicated by a single tooth flipper or 3-unit fixed partial denture. If the patient will accept, it will be okay. If no, we need to go for, we need to graft this ridge by autogenous bone graft, then an implant, or implant simultaneously with guided bone regeneration, or by split maxillary ridge and implant and GBR all the same time. You know that in the maxilla, because the bone is spongy, so we can expand, we can use the split maxillary technique. So the patient decided to put an implant, especially when the implant is offered for free for the UAE citizen in our government service, dental services. We decided to go for the split ridge. So you can see the crestal incision with the mesial release, C-type mesial release, to have a better access to the defect, and when we reposition, it will be easier to put the suture the flap in place. We need to do full thickness flap. You can see how the ridge has a buccal concavity and a thin ridge. Then we started with our piezo. We do the horizontal bone cut. The ridge, then we need to do a small vertical cut to allow for an expansion, and then using the pilot drill coming from the system, and then the twisted drill, number 3, and by using the osteotome to be able to expand. Implant was placed, and to support not to have crestal bone resorption, I immediately fit the healing collar, and then using the implant, it's a bone level implant system, but I used it to do it subcrestally. It's a narrow platform diameter, 3.4, and then to prevent the resorption of this buccal plate, a mixture of autogenous, a mixture of xenograft and C-coral has been used, and a resolute resorbable barrier has been placed in the buccal area with mucosal split and periosteal dissection to have a primary closure. And that's the healing. We waited 6 months to do the second stage uncovering. We can see the healing stage. We have very good contour, good healing, still good attached gingiva. On opening, we can see that there is a blood. That means we have a vital blood, a good bone around the implant platform. And we fit a longer healing collar to be able to start the prosthetic impression. Then, when we do the guided bone regeneration, always it's preferable that we put a temporary crown to use the concept of bone training, because the patient has been for some times without tooth, and to test also our bone quality and the osseointegration of the implant. So temporary has been used for 13 months for progressive loading. As I told you, bone training. Screw retained crown was done. We can see with the peri-implant, we have a very good peri-implant mucosa to the probing resistance, healthy, and how we have a harmonious contour, and we have almost the same level of the cervical peri-implant mucosa with the implant with the adjacent teeth. So the case was well planned from the beginning. Then the final ceramo-metallic crown. You can see, maybe you can criticize the crown. I don't do restorative. This is colleague working with me. Maybe the crown need to be, the color need to be better. We have good contour, good papilla fill, good buccal plate, and harmonious gingival scalloping. Now, we can go a little bit more further than the conventional cases, especially that I knew that there is maxillofacial people working also and maybe attending this. This is the recent case, patient with the proper logical sequence. He's a class 3 skeletal case. You can see cephalometric, has been planned by our one of our colleague in Rashid Hospital with the orthodontist. The orthodontic trend has been done, started, then the orthodontic surgery, the bimaxillary surgery has been performed, the maxillary advancement, and the sagittal setback osteotomy of the mandible with plating. And this is, I believe, Dr. Park, his main of his job. And then the patient, after healing, the corona lockdown has been in March. He waited that the dental clinic will be operating again. He has been referred to me because I am part of the maxillofacial team. And we performed a bone level implant to replace his missing first lower right molar, the tooth number 30 or the lower right 6. On this periapical X-ray, maybe if somebody he can misjudge or do interpretation, he can say, oh, this implant is touching with the plate. No, we know that with the plating of the sagittal split osteotomy, it's at the angle of the mandible. Other cases that maybe we can face almost daily in our practice. And this is, we have a good logical sequence. The patient complained of this tooth fracture. He had a traumatic fracture of his prosthetic crown on his upper lateral. There is no root canal. And you can see how the tooth is moving, and they need an immediate replacement. And he had a low smile, so he said, okay, I don't want to have an immediate temporary whatever flipper, or I can wait for the final crown. So immediate extraction has been done by the periotome. Because it is a lateral, always to select a narrow diameter implant in a 3D positioning. You can see that the implant is always towards the palatal, and it should be minimum 1.5 millimeter adjacent from the tooth, left and right, and 3 millimeter below the crestal bone when it is extraction, because we need to consider the socket extraction, socket remodeling. And you can see that the jumping space, when it is 2 millimeter and more, we need to graft it. So particulated, the xenograft has been used, suturing, and the second stage because it's an open extraction socket. And we have good primary stability. The patient is happy, and he says, I don't want temporary. I can wait 2 to 3 months to have my final crown. And that's the X-ray. Sure, because you can tell me now on the X-ray the tooth is the implant is interfering with the root of the central. No, it's a 2D X-ray. You can see clinically that I'm more towards more toward the palatal bone. what we can suspect to plan good, maybe before having the final crown, soft tissue enhancement is needed by adding a little bits of tissue, connective tissue, if we feel that the buccal cortex has some concavity due to the extraction remodeling. Now, an extraction, and also when it is well planned, this is done in my private practice, when you have your colleague working together, better than being referred from one place to other. So extraction, immediate implant, and immediate temporary has been performed. Unrestorable tooth, you can see this left central with poor root canal, recurrent caries under the crown, extraction, the pin guide to see the paralleling and the proximity with the nasal floor, immediate implant, impression done directly. And then this is the result after 2 years. You can see beautiful crown, beautiful bony integration, good soft tissue seal. And I think the aesthetic is reasonable. The level of the cervical margin of the natural tooth and the implant is satisfactory. Maybe we have a little bit the flat buccal contour because this is it was done in extraction and immediate implant, but the patient is not concerned at all. Her smile is satisfactory. She's very happy. Now we are almost at the end. So sometimes a patient will come, will attend our clinic, referred by a colleague. Years ago, in my practice, when I see this upper edentulous right side, I tell the patient, you don't have enough bone. We need to do sinus lift because we are trained to use long implant. But these days, with the advancement in the implant system, in the implant surface, and the design of the implant, we can give other alternative to the patient by using short implant. So we used the first regular implant, 11 millimeter, and the second 7 millimeter implant. But because it is short, I always prefer to submerge the implant at least for 3 months. Now, we discussed if there is a logical sequence or there is no logical plan. So if the treatment is not logically planned and developed, what will happen? We will have a failure in execution of our treatment. The patient will not be satisfied, more cost, time is lost, the patient keep on going between the specialist and the restorative dentist, and an improper use of the resources will happen. You know, when we work in a hospital setting or a specialty center and we have a junior colleague to train, and as the implant is booming all over the place, well, I always tell them, you know, the implant drilling steps is very easy to be done. Even if it is a hands-free implant placement, and even for me as a specialist surgeon doing this work daily, especially now with the newly navigated guided implant, I don't feel that my skills are useful. So, but when we compare this to a surgical extraction of a wisdom tooth, for example, in horizontally impacted, or a disc to angular impaction, you know, extraction is more difficult. Implant placement, that means the sequence osteotomy steps are very easy, but the most important, you know, it's the planning. The most important is the planning. So the message to take home, we need to have a positive diagnosis when we start. We need to predict the prognosis. We need to have a logical sequence of our treatment plan. This treatment plan should be agreed by the surgeon, by the restorative dentist, and approved by the patient. A good communication between our general practitioner and specialist to avoid having this referral without the patient being prepared, and importance of saving time and resources, and the importance of enhancing our skills. Our skills will improve within time. Always we learn and we keep on learning. And especially these days, we should take the benefits of using the new digital technology, the navigation, the cone beam CT for diagnosis and for treatment planning. And thank you for attending, and I'm ready for questions.